Hello students. In the central nervous system unit, today I'm starting the diseases or the disorders which comes under the mental illnesses. Mental illness, which is a medical term. Under the mental illnesses, we have various group of disorders comes in. And in that way, there is one classification where mental illnesses can be classified into psychosis and neurosis. Psychosis again will have other disorders in it as cognitive disorders, where delirium and dementia kind of condition comes, and functional disorders where schizophrenia, which we also call it as a split mind state, paranoid state, and then mood disorders. Mood disorders have mania and depression. So this comes under the psychosis. Another condition called neurosis, another group of disorders called neurosis. Compared to psychosis, considered these neuroses considered as less serious, and the neurosis have other disorders as anxiety, obsessive compulsive disorder, post-traumatic stress disorders, hysterical, reactive depression, phobic states. So these are certain mental illnesses which are there under the central nervous system. In this, some of the diseases and their treatments or their managements will be covered under this chapter. So this chapter we call it as a psychotropic drugs. So we'll see what these psychotropic drugs are covering. So when we see the psychotropic medication, we can divide this psychotropic medication into stimulants, antidepressants, antipsychotics, mood stabilizers, anti-anxiety agents. So we will take the first one here, that is the anti-anxiety drugs. So anti-anxiety drugs, before that before we discuss about the anti-anxiety drugs or the treatment of anxiety, first we should understand briefly what the anxiety is. So anxiety can be defined as an exaggerated feeling of apprehension, uncertainty, and fear. These words there in this chapter you will find lot many words which we are using in our daily life. We say worries, we say apprehension, fear, but certainly these words directly associated with the sign and symptom of kind of mental disorder. Okay, so we are saying it as these conditions, these feelings of apprehension, uncertainty, and fear, when they get in exaggerated state, exaggerated state. So that state will be considered as a disorder. Another way we can define it as an emotional state, unpleasant in nature. Of course, it is unpleasant in nature, associated with uneasiness, discomfort, and concern or fear about some defined or undefined future threats. This is something very interesting, that the patients will be having certain kind of fears which are defined. Sometimes they are defined fears, sometimes those fears are undefined for future threats. There is another way to explain the anxiety, is that in state of anxiety, the normal fear response to threatening stimuli comprises defensive behavior, Autonomic reflexes, arousal, alertness, and negative emotions occur in an anticipatory manner, independently of external events. Means what? There is no any threat or a threatful condition around a subject, but the subject will receive it as a threat. And then when it receive it as a threat, the subject will show the defensive behavior against that threat which is actually not there. And then the subject will show lot many defensive behaviors like autonomic reflexes, arousals, alertness, and certain negative emotions as well. So anxiety appears because of some stimuli. So of course, always when there is a condition, there is a kind of a stimulus. So it also has certain stimulus. On ANS, triggering somatic and visual responses, if you see what kind of stimuli is and affecting which part. So if you see the stimuli affecting on ANS, what kind of? It is triggering somatic and visual responses. On hypothalamus pituitary endocrine system, means these stimuli are also affecting or acting on hypothalamus pituitary endocrine system. By that, the disease, the subject will show various signs and symptoms of this disorder. For example, fatigue, so fatigueness or fatigability, dizziness, palpitation, indigestion, headache, muscle pain, insomnia, and increased perspiration. So these are certain group of signs and symptoms what the person is showing. Here in as per the different reasons as and the symptoms, the anxieties and their types are being differentiated. So various types of anxiety we can define. First is as cardiac neurosis. It is unfounded fear of heart disease, palpitation, functional precordial pain. GI neurosis, fixation on bowel movement, distension, reflexes, and acidity. Next is social anxiety, fear of being observed, evaluated by others. So what happens in social anxiety? The subject always feels that somebody is watching him or somebody is evaluating him. So they'll always be very conscious for it. Next type of is obsessive compulsive disorder, OCD. Fear of contamination. For example, somebody is very obsessive for something or sometimes very compulsive for something, right? For example, the fear of contamination. Somebody is very much prone to cleanliness, always think about cleanliness even when there is everything clean. Next is the post-traumatic stress disorder. You know very well, whenever somebody had any kind of stressful experience in the past, and when they recall it again, they go again into the similar kind of stressful conditions. Next is the panic disorder. Panic disorder where the subject will go to sudden attacks of overwhelming fear with the symptoms like sweating, tachycardia, chest pain, trembling, and choking. And the another form is the various forms of phobias. So phobias also comes under it. So phobias can be, strong fears of specific objects or situations, as for example, as snakes, open spaces, flying, social interactions, height, etc. So these are various phobias which are there. So likewise, these are many type of anxiety, or you can define the anxiety in many ways. So before going into the treatment and the management of anxiety, here we should go through the anti-anxiety drugs, which we also call it as anxiolytics. In this we have these 5 main classes. Number one is the benzodiazepine. You have already gone through the benzodiazepine when I have discussed about sedative hypnotics in the previous videos. There you have seen in detail of the benzodiazepines. So here also the benzodiazepine, one of the very important class. Examples are diazepam, chlordiazepoxide, oxazepam, lorazepam, alprazolam, helazepam, prazepam, midazolam, triazolam, flunitrazepam. Here another class is there, which is actually a new class here. It's called azapirons. The examples of azapirons are buspirone, gpiron, or ispapirons. Sedative antihistaminics, this is also a little newer class here, hydroxyzine and diphenhydramine. And surprisingly, you can find a beta blocker here. Later you will understand why the beta blocker is here. So beta blocker, and I think if you remember my video on beta blocker, there I have mentioned this particular point, that why propranolol is showing some anxiolytic effects. So here propranolol is an example. Another one is the meprobamate that you will see in the coming slides. Miscellaneous drugs are also there, which are not directly anxiolytics, but they are doing that job because of having some similarity in mechanisms. For example, chloral hydrate, methaquilone, zolpidem, SSRIs, fluoxetine, fluoxamine, paroxetine, sertraline, citalopram, escitalopram. So this is the examples of selective serotonin reuptake inhibitors, SSRIs. Okay, now we'll begin with the benzodiazepine class. Already, as I told you, you have already gone through with the benzodiazepine, the exact mechanism, its pharmacological action, uses, and everything. So here I will not discuss everything in detail about benzodiazepine, but I'll discuss only the benzodiazepine's effect in anxiety, what it does. That's only. How it does, already you know the mechanism of it. The main effect of benzodiazepine are reduction of anxiety and aggressions, sedation and induction of sleep, reduction of muscle tone and coordination, anticonvulsant effect, anterograde amnesia. Benzodiazepine obliterate memory of events as minor surgical procedures, right? At anti-anxiety doses of benzodiazepine, cardiovascular and respiratory depression is minor. So these are the effects of benzodiazepine in anxiety. The rest of the things you can refer the sedative hypnotic video. Here this is small diagram which will tell you the metabolism of certain benzodiazepine and their active metabolite formed. So you can see chlordiazepoxide forms demoxepam, which is an active metabolite for it. You know that they all are converted into active metabolite and play and produce their effects. Same way you can find chlorazepate, which converts into nordazepam. Here diazepam, prazepam, helazepam also convert into nordazepam, which is again convert into oxazepam. Here also lorazepam, flurazepam, temazepam, alprazolam, triazolam. By various mechanisms, they convert into the various metabolites, right? And after these metabolism, maybe they form the inactive products, and they go through urine. Here I would like to mention one important information with you. Uh, that one agent is there which we call it as 10 kDa peptide is a diazepam binding inhibitor. Actually, this inhibitor is isolated from the rat brain and is an indigenous ligand for the benzodiazepine receptor. Sorry. This peptide strongly binds to the benzodiazepine binding site of the GABA A receptor and has the opposite effect to benzodiazepine. That is, it inhibits chloride channel opening by GABA and has anxiogenic and pro-convulsant effect. So remember the name of this 10 kDa peptide. Now I would like to move to our main or the newer class here. Actually, benzodiazepine is very much used, but that already you have studied. So here I am going to talk about the new class, that is azapirons. Buspirone is the drug what we are taking here as a prototype. Buspirone is actually the first azapirone which is discovered, and this we found that it is quite different from the benzodiazepines. This drug produces no significant sedation or cognitive functional impairment, no interaction with benzodiazepine receptor or modify GABAergic transmission, no tolerance, no dependence, no withdrawal symptoms, no muscle relaxant activity, and no anticonvulsant activity. We'll see how this buspirone acts. You know pretty well that how benzodiazepine acts, but now we'll see how buspirone acts here. You can find the buspirone, which is a selective partial agonist of 5-HT1A receptor. So what it does, although buspirone has been shown to interact with a number of neurotransmitter systems in the brain, it appears that its clinical relevant effects are mediated through interaction at the 5-HT1A receptor, where it acts as a partial agonist. By stimulating presynaptic 5-HT1A autoreceptor, it reduces the activity of dorsal raphe serotonergic neurons. Already you know very well that whenever autoreceptors get activated, they always do these synaptic intake, and because of that the amount of neurotransmitter or concentration of neurotransmitter at synaptic cleft reduces and some kind of antagonism effect will be produced. Antagonism at certain postsynaptic 5-HT1A receptor has also been demonstrated. So like that it acts on the 5-HT1A autoreceptor and reduces the activity of dorsal raphe serotonergic neurons. This is the mechanism of buspirones. After chronic treatment, adaptive reduction in cortical 5-HT2 receptors may occur. Buspirone has weak dopamine D2 blocking action but no antipsychotic or extrapyramidal effect. Buspirone is well absorbed from the gastrointestinal tract and peak blood plasma level are achieved in 1 to 1.5 hours. The drug is more than 95% bound to plasma proteins. Bioavailability is generally less than 5%. We can find the extensive first pass metabolism, usually found very well absorbed, and the excretion is usually by urine and the feces. Now we'll see the pharmacological effects of buspirone. Is an effective as the benzodiazepine in the treatment of general anxiety. So its potency we can it is like a comparable with the benzodiazepine. However, the full anxiolytic effect of buspirone takes several weeks to develop, where the anxiolytic effect appears in a few days of therapy. What do you mean by it? The full anxiolytic effect. So all the anxiolytic effect what is expected from the buspirone will appear after several weeks, but anxiolytic effect it appears in a few days of the therapy itself. In addition, buspirone does not potentiate the central nervous system depression caused by sedative hypnotics, so it is not doing you know the addition in the depression caused by the sedative and hypnotics or by the alcohol, and it does not prevent the symptoms associated with benzodiazepine withdrawal. The most common side effects are dizziness, lightheadedness, and headache. So this is about the buspirone. Now I would like to mention here one more very important drug. This drug again will be discussed in the next chapter, antidepressant. So there I will not give much detail about it. So meprobamate, it has a similarity with the benzodiazepine and barbiturates, but more similarities found with the barbiturates. No significant advantage over benzodiazepine has found, while we found that it is more toxic and more addicting. What is the mechanism here? We'll see the mechanism and pharmacological action. Acts on several level of CNS as limbic system, thalamus, and spinal cord, but it is not depressing the RAS system of the brain. But it can produce, mild to moderate tranquilizing, anticonvulsant, and skeletal muscle relaxant activity. It acts by inhibiting multineuronal spinal reflexes, as well as it decreases the REM sleep time. On prolonged use, hepatic enzyme induction, it does the hepatic enzyme induction. If you give it for a long time, it will induce certain hepatic enzymes. In increased dose, it can be act as a cardiorespiratory depression. It can produce the cardiorespiratory depression, used as alternative in anxiety treatment. It's not a main line of drug, but always as an alternative we are using it. There are certain ADR of the meprobamate: drowsiness, ataxia, slurred speech, depression, paradoxical excitement, euphoria, hypersensitivity, where leukopenia, agranulocytosis, thrombocytopenia, aplastic anemia, and pancytopenia have been found. Habituation and dependence are also there. In overdoses, there will be lethargy, stupor, ataxia, cardiorespiratory collapse, arrhythmia, shock, and death. So these are some ADRs of the meprobamate. So here I would like to add certain assignment for you. Assignments like pharmacology of benzodiazepine, which is already discussed in sedative hypnotic chapter, as well as the pharmacology of specific drugs, for example diazepam. So maybe the question can be asked directly by diazepam. So diazepam, chlordiazepoxide, alprazolam, oxazepam, lorazepam, zolpidem. So these drugs individually you can prepare as an pharmacology of benzodiazepine. Also, pharmacology of beta blockers in anxiety, hydroxyzine and diphenhydramine. So these drugs also you need to be prepared with it. Thank you for listening this video. Wait for the next video where we'll discuss about the antidepressant